Good evening, and thank you for being here. Tonight is the fourth presentation for the month of October here at Cady Wellness Institute, and this month we have been discussing Vaccine Injury Awareness Month. We started out the month with a presentation entitled Autism is Treatable, and the second presentation was Autism is Medical. The third presentation was a presentation about environmental toxins and vaccines and genetics and the interaction between all of these multiple factors. And tonight we're really going to delve into vaccinations. And I would like to say that my wonderful friend and colleague, Dr. Cady, has no idea what he's done to me this week. When we started talking about this series, Dr. Cady's question was, or his suggestion was, that I discuss the 3 most dangerous vaccines that you can receive. That was really difficult to decide which 3 are the most dangerous, and I was not able to do that. So I apologize to you, Doc. But as is often the case, one thing leads to another and the trail goes where it goes. So we're going to discuss more than 3. We will have 4 that are going to make the top echelon there, or the lower echelon, however you want to discuss. But we're going to start off with, I was trying to think about what questions people might have about vaccines. So the first question that people tend to ask is, do vaccines cause autism? That seems to be the one thing that most people associate with vaccine damage is autism. So I want to just say this, the CDC says, the science says no. There's some problems with the CDC's studies. The CDC has focused on the MMR vaccine, which is measles, mumps, rubella, and their studies have also focused on thimerosal. The MMR is actually 3 vaccines. It's 1 injection that contains 3 different vaccines. So that's 1 3-vaccine injection. And thimerosal is 1 ingredient of a long, long list of ingredients. There are problems even with those studies. The MMR research most recently has been associated with something called the CDC whistleblower. I don't know if anybody here has heard about that, but I'm going to talk about that in just a minute. The MMR research has this whistleblower research was included in a whole body of research, but really focused on this type of research with these same researchers, and that research has been relied upon heavily by the CDC. Same thing with the thimerosal studies. Paul Thorson is a big problem, and I don't know if anybody here has heard of Paul Thorson, but we're going to talk about him as well. The Institute of Medicine in 2004 said, do not look for susceptible groups. In their instruction, the 2004 Institute of Medicine Vaccine Safety Review, on the executive summary on between page 12 and 14, it states, do not conduct research that would identify susceptible groups of children who might be more vulnerable to vaccine injury. They've also said, conduct only epidemiological studies. Why would they only conduct epidemiological studies? Epidemiological studies can never be used to establish causation. Whenever you hear somebody who's pro-vaccine talk about the research, and they'll say, the research does not show a causal association between vaccines and autism. That's because the research that they're doing cannot show causality. It can only show correlation. So when they say correlation does not equal causation, it's a self-fulfilling prophecy, and they have set the prophecy. Go back, I just skipped one. Okay, so talking about the whistleblower, this is a piece taken directly from the public release of August 24th, 2014, the press release that was put out by the whistleblower attorney, the attorney who specializes in whistleblowers, who is now representing Dr. William Thompson, who is the PhD scientist from the CDC who put out this statement. And this is just part of it, but he says, "My name is William Thompson. I am a senior scientist with the Centers for Disease Control and Prevention, where I have worked since 1998. I regret that my co-authors and I omitted statistically significant information in our 2004 article published in the journal Pediatrics. The omitted data suggested that African American males who received the MMR vaccine before age 36 months were at increased risk for autism. Decisions were made regarding which findings to report after the data were collected, and I believe that the final study protocol was not followed." For anyone who doesn't understand research and the way research is conducted, that's fraud. This is also really big, because what should have happened in research, when you have a statistically significant finding, it doesn't mean that it proves anything, but it opens the gateway for more research. So when they found that African American males in inner city Atlanta who were vaccinated before the age of 36 months with the MMR vaccine were almost 240%, had an increased risk of almost 240% for developing autism when compared to other children, or children who were not vaccinated before 36 months. What should have happened was the researchers should have said, we need to conduct more research. We need to look at other children to see if this is just for African American males. We need to see if it's also true for Hispanic males, for children living in other areas of the country, for other vaccines, for the schedule itself. What they did is they said, we are not going to address this, and they eliminated 40% of the study population of African American males, which decreased the power and eliminated the statistical significance. It's about much, much more than just African American males and MMR. That took place in 2001. The study was eventually published in 2004, and almost immediately after that was when the Institute of Medicine said, do not look for susceptible groups. There's a whole domino effect there. So Paul Thorson was a researcher at the CDC who authored or co-authored 21 of 24 studies the CDC claims disprove any link between vaccines and autism. Thorson now tops the federal most wanted list for 22 counts of wire fraud and money laundering, and if he is ever caught, he will face 260 years in jail. And the CDC is still relying on that research to say that vaccines do not cause autism. This is Bernadine Healy. She was a very mainstream doctor. She graduated from Harvard Medical School and was the first woman to direct the National Institutes of Health. In 2008, she was interviewed by Cheryl Atkinson, a really top-notch journalist. And Dr. Healy said, I think that the public health officials have been too quick to dismiss the hypothesis as irrational. And what she was talking about was the hypothesis that vaccines cause autism. She goes on to say, public health officials have intentionally avoided researching whether subsets of children are susceptible to vaccine side effects, afraid the answer will scare the public. Dr. Healy told Cheryl Atkinson asked her, you're saying that public health officials have turned their back on a viable area of research largely because they're afraid of what might be found? And Dr. Healy's response, she said, among my colleagues at the Institute of Medicine, there is a completely expressed concern that they don't want to pursue a hypothesis because that hypothesis could be damaging to the public health community at large by scaring people. First of all, Healy said, I think the public's smarter than that. The public values vaccines, but more importantly, I don't think you should ever turn your back on any scientific hypothesis because you're afraid of what it might show. That was in 2008. In 2014, just a couple months ago, in August, William Thompson came out and admitted that they eliminated data and broke the study protocol to hide the fact that they found susceptible groups. So nothing has changed. It's still going on.
And why isn't that hitting the press?
Exactly. The question is, why isn't that hitting the press? A couple of weeks ago, I sat through 30 minutes of CBS Evening News. And during that 30 minutes time, there were 8 pharmaceutical commercials. And that's why it's not hitting the press.
Yeah.
Money.
Amen.
So what does independent research show? This is a study that was published in Acta Neurobiological Experimental 2010, and the title, Influence of Pediatric Vaccines on Amygdala Growth and Opioid Ligand Binding in Rhesus Macaque Infants, a pilot study. They looked at 2 sets of macaque infant monkeys, and they looked at the infant macaques because they share 93.5% of the DNA with humans. One set was unvaccinated and one set was vaccinated with the 1990s pediatric vaccination schedule. What they found, the contrasting results were remarkable. The vaccinated monkeys showed increased brain growth, which the authors theorize may arise from the inability to prune neurons. Larger head size is a hallmark of human infants who later develop autism. The vaccinated primates also showed a different rate of maturation of the amygdala section of the brain than the non-vaccinated monkeys. Amygdala dysfunction has been long implicated in autism. The amygdala region is responsible for emotions, memory, and learning, and individuals with autism often struggle in these areas. This is something else that Dr. Healy talked about in her interview with Cheryl Atkinson, is that we need to go into the lab and look at the animal studies, particularly those that are done with primates. These monkeys developed autism when they were vaccinated according to the schedule that we're using on our children. So this is another study, aluminum vaccine adjuvants in autism, and the title was, Do Aluminum Vaccine Adjuvants Contribute to the Rising Prevalence of Autism? And I quoted it down here because it's kind of hard to see there. Our results show that children from countries with, what they did is they looked at the different countries across the globe and their vaccination schedules and the amount of aluminum that is injected in vaccines. Now remember, the CDC has looked at thimerosal. They've never studied, the CDC has never studied aluminum in infants and in the vaccination schedule. There's no study on the safety or efficacy of injecting infants with aluminum, and infants are vaccinated, depending on what vaccines they receive, they're vaccinated with up to 1,200 micrograms of aluminum within a matter of seconds at their 2-month, 4-month, 6-month, and 1-year vaccine appointments, otherwise known as well baby checks. According to the FDA, the limit for a 10-pound infant for aluminum in a parenteral solution, an IV solution, would be about 30 micrograms of aluminum over a 24-hour period. And they're being injected with up to 1,200 micrograms like that. So what these researchers found was, our research showed that children from countries with the highest autism prevalence appear to have the highest exposure to aluminum from vaccines. The increase in exposure to aluminum adjuvants significantly correlates with the increase in ASD prevalence in the United States observed over the last 2 decades. And a significant correlation exists between the amounts of aluminum administered to preschool children and the current prevalence of ASD in 7 Western countries, particularly at 3 to 4 months of age. So this is what has not been studied. This is the 2014 United States vaccination schedule. The CDC's childhood vaccination schedule has never been studied, and the safety or efficacy of vaccines as administered has never been studied. There's not one single study that looks at what happens when an infant goes in for their 2-month vaccination appointment and they get the hepatitis B vaccine, the rotavirus vaccine, diphtheria, tetanus, and acellular pertussis, which is 3 vaccines, Haemophilus B, pneumococcus, and inactivated poliovirus. These infants are getting between 8 and 10 vaccines, if you come down here, all at the same time, and that's never been studied. Not studied for synergistic effects, not studied for how they're even effective if given like that. We wouldn't go to the doctor as adults and think that it's okay for the doctor to hand us 8 prescriptions and say, start taking these right now, and oh, you don't have to worry about side effects, you don't have to worry about interactions, it's safe. And it's safe for 100% of the population, because this is what we're supposed to believe is safe for 100% of our infants. I'm going to show this right now. This is actually, and I brought this because I think it really demonstrates, and this is also, part of this is in here, but this is the 1983 vaccination schedule from the United States. All of this. And here are the recommendations. This is the 2014 vaccination schedule with all of the recommendations. And they've crammed it onto all of these pages. This should be one full page. This should be one full page, because the writing is so tiny you can't read it. When this was the schedule, autism in the United States was 1 in 10,000. And now this is the schedule, and autism among 3-year-olds is 1 in 21. This is a study that was published in September of 2014, right there, September 24th, 2014, and it looked at the infant mortality rates in the United States compared with other countries who are in the Organization for Economic Cooperation and Development. The United States ranks last for infant mortality rate. This is the number of infants that die before their first birthday in the United States. It's 6.1 per 100,000 live births. 3 times, almost 3 times, Finland, Japan, Portugal, Sweden, Norway. When they looked at Sweden, and they compared, in the past, previously, we've known this has been a problem for some time with the infant mortality rate. More babies die in the United States before their first birthday than any other developed nation. The answer for that has always been that's because the United States goes to huge lengths to keep babies alive, even when they're born at 22, 23 weeks gestation. So knowing that that's an issue, they took out any babies from this study, any births that occurred before 24 weeks. And they still found that only 39% of the difference between the United States and Sweden was due to preterm births. 47% was due to higher infant mortality rate among full-term babies. That's new information. For infants born at 37 weeks of gestation or more, the United States infant mortality rate was highest among the countries studied, and about twice the rates for Denmark, Finland, Norway, Sweden, and Switzerland. So here we have 2.1 for Finland and Sweden, 2.2 for Denmark, 2.5 for Norway, 2.5 for Switzerland, and where are we here? 4.2 for the United States. So what's different between the US and other countries? The number of vaccines given in the first year of life. Finland gives 15, Sweden gives 12, Denmark gives 12, Norway 12, Switzerland 17, and the United States 25 to 26. When you look at the difference here, in the 1980s, children between birth and 18 years of age got 23 vaccines by the time they were 18. And down here, they get 26. If they get the flu shot during the pregnancy, 26 vaccines by the time they're 6 months old. Okay, so this is Finland's vaccination schedule. And you'll see at birth, only BCG, which is, I've just lost it. BCG is what we test for. Tuberculosis, thank you. Yes, tuberculosis. So BCG at birth, but only if, it's on here somewhere, BCG is given only to children considered in high-risk groups. So it's not given to everyone. It's only high-risk groups. And all they give The first round of vaccines is at 3 months. And they give DTaP, Hib, inactivated polio, and pneumococcal, and rotavirus. Sweden has BCG and hepatitis B, but only for high-risk groups. All babies don't get them. Only for high-risk groups. At 3 months, they give DTaP, polio, Hib, and pneumococcal. In Denmark, hepatitis B, only for high-risk groups. Nothing else at birth. 3 months, DTaP, Hib, polio, and pneumococcal. Norway, same thing. Only high risk, and that's all they get at 3 months. Same thing for Switzerland. So you get the idea there. And there's a closer look at our schedule in 1983, which is very similar to theirs. Our kids would get 2 months, they would get DTP and polio. 4 months, DTP and polio. 6 months, DTP. And that's all they got in the first year of life. That's it. Now they get 26 by the time they're 6 months old. So again, this is what we were looking at here with, this is all what they get by 6 months. So hepatitis B is one of the big differences between those countries that have much lower infant mortality rates than the United States. So the question is, when we start thinking about, is a vaccine necessary? Does it work? Does it make sense to give it? We want to do a risk-benefit analysis. So the question is my child at risk for hepatitis B? Hepatitis B is not common in childhood and is not highly contagious. It's primarily an adult-onset disease or adult disease transmitted through infected body fluids, most frequently infected blood. It's prevalent in high-risk populations such as needle-using drug addicts, sexually promiscuous heterosexual and homosexual adults, residents and staff of custodial institutions such as prisons, healthcare workers exposed to blood, persons who require repeated blood transfusions, and babies born to infected mothers. And they know if those babies are born to infected mothers because every woman in the United States is tested for hepatitis B when she's pregnant. So why are we vaccinating infants, 100% of our infants on the first day of life, when we know who has a mom who's positive and who's not? The CDC prevention guidelines from 1997 says the sources of hepatitis B infection for most cases include intravenous drug users, 28%, heterosexual contact with infected persons or multiple partners, 22%, and homosexual activity, 9%. Although CDC officials have made statements that hepatitis B is easy to catch through sharing toothbrushes or razors, Eric Mast, MD, Chief of Surveillance Section, Hepatitis Branch of the CDC, stated in a 1997 public hearing that although the hepatitis B virus is present in moderate concentrations in saliva, it's not transmitted commonly by casual contact. So how serious is it? It's not a killer disease for most. The symptoms of hepatitis B infection are nausea, vomiting, fatigue, low-grade fever, pain and swelling in the joints, headache, and cough that may occur 1 to 2 weeks before the onset of jaundice, yellowing of the skin, and enlargement and tenderness of the liver, which can last for 3 to 4 weeks. Yuck. You're not going to feel good. Fatigue can last up to a year. Again, yuck. So you will feel really yucky for 6 to 8 weeks, and it may take you a year to recover your energy level to pre-illness status. Harrison's Principles of Internal Medicine in 1994 said in cases of acute hepatitis B, most patients do not require hospital care. 95% of patients have a favorable course and recover completely. Case fatality ratio is very low, approximately 0.1%, 0.1%, or about 1 out of 1,000. Those 95% who recover completely from hepatitis B infection acquire lifelong immunity. Of those who do not recover completely, fewer than 5% become chronic carriers of the virus, with just 1/4 of those in danger of developing life-threatening liver disease later in life. So when you do the math, if you got 5% of 5%, you got 0.25, 1/4 of hepatitis B cases. So of the 5% of people who do not recover completely from hepatitis B infection, 5% will become chronic carriers, and 1/4 of them will eventually die from hepatitis B related disease. So again, more math. This is in 1990, which is right at the time when they added the hepatitis B vaccine to the childhood schedule. Prior to that, it was not in the childhood schedule. Now, I want you to think about how hepatitis B is spread and what else was happening at that point in time. We had HIV, AIDS, we had a lot of education about how these are spread, promiscuous sex, drug use, okay? So in 1990, there were 21,102 cases. And so if we use that formulation, this number will recover completely. Of the 5% who do not recover completely, 5% will become chronic carriers, 1/4. Okay, so 1,055 will not recover completely. 58 become chronic carriers, and 13 succumb to liver disease later in life. So is the vaccine working for children? The reason they added it to the childhood schedule is because prior to 1990, they were targeting adults, specifically at-risk adults, and they hit a wall. They couldn't bring it down any further. So they decided the best way to get everybody is to get them at birth. And that's when they added it to the schedule. It wasn't because children were at risk. It was because they couldn't bring the adult rate down any further. So this is 1996 data from the CDC. There were 10,637 cases of acute hepatitis B disease in children. At all. So by 1996, this was the overall. And there were 279 cases were in children under 14 years of age. So that's 2.62 of 10,637. So that's the childhood, that's the burden among children. Is it decreasing the rate of illness and later deaths from liver disease in children? We need to look at the data beginning before the mass vaccination of infants. So in 1990, the overall rate of hepatitis B infection was 21,102. So if we use that 2.62 rate, we can estimate the number of cases in children under 14 as 552 point something or 553 cases. In 1990, we'll estimate there were 553 cases in children under 14. In 2002, the overall rate of hepatitis infection reported in the United States was 8,064. Using the 2.62 rate, we estimate the number of children under 14 as 211 cases. So from 1990 through 2002, bear with me, I know this is a lot, we can estimate the number of cases of hepatitis B infection in U.S. children under 14 years of age has decreased by approximately 230 cases overall. All right, over that per year. So 1991 to 2011, that's a 20-year span of mass vaccination of infants. 230 cases per year prevented as a result of mass vaccination. That's estimated 4,600 total number of cases that may have been prevented in children. They generally have a milder case of the disease. So we don't have a number for that, so we'll go with that higher number of 5% not fully recovering. So if we do the math again, there's 230 not fully recovered, 11.5 become chronic carriers. That's over a 20-year span. 11.5 children would have become chronic carriers. 3 would have died later from liver disease. So approximately 3 deaths among U.S. children under 14 years of age may have been prevented in the first 20 years of universal vaccination of infants against hepatitis B infection. So how many children have died from the hepatitis B vaccine? As of September 14th, VAERS' Vaccine Adverse Events Reporting System. It's maintained by the United States Health and Human Services. It was established after the 1986 Childhood Vaccine Injury Program was established. The law was established that gave vaccine manufacturers indemnity from liability if a vaccine injures or kills someone. It's supposed to be a mandatory reporting system, but estimates from the American Academy of, AMA, the American Medical Association, are that somewhere less than 10% of all vaccine reactions is reported to VAERS, and it's probably somewhere between 1% and 2%. And that's because even though the law says it's mandatory, there's no training of doctors or nurses to recognize vaccine reactions. I have a couple of friends on Facebook who are nurses and have children who are vaccine injured, and one nurse mentioned to me she's been a nurse for about 30 years. She said that she's only met one other person in the healthcare field that even knows about the 1986 law or about vaccine adverse events reporting system. So as of September 14th, 2014, deaths among children under the age of 17, there were 844 deaths from hepatitis B reported to VAERS. 804 were in children under 3 years, and 773 deaths in infants under 1 year. So clearly it is not working for children. Does it work at all? This is here at the Cady Wellness Institute. When I see someone who has a suspected vaccine injury, one of the things that we do a lot of labs, a lot of tests. One of the things that we do is we check titers. We check vaccine titers to see if the child has developed immunity from the vaccines that he or she got as an infant. This is from a 4-year-old female, fully vaccinated as an infant, and she has no evidence of immunity to hepatitis B. So the vaccine didn't even work. She took all the risk for zero benefit. So let's talk about DTaP. Diphtheria, tetanus, and acellular pertussis. The first thing I want to say about DTaP is that the reason DTaP was developed in the first place is because there were too many deaths associated with the whole cell pertussis vaccine, DPT or DTP. DTP was the reason why the 1986 vaccine injury law was passed in the first place, because too many vaccine manufacturers were being sued when children were dying. And they went to the government and asked for protection. Actually, they went to the government and blackmailed them for protection. They said, if you don't protect us from lawsuits, we will stop making vaccines altogether. So they have complete liability from anything if a vaccine injures anyone, which gives them no incentive to produce a safer product. So DTaP was developed because it was assumed that the acellular pertussis component was safer than the whole pertussis component. How they tested that was not by giving DTaP in the clinical trials, they did not give DTaP to a group of children and then give placebo or saline to a group of children to see how they reacted. They compared DTaP with the whole cell pertussis, DPT, GTP. And they looked at the incidence of severe adverse reactions between the two groups, and because DTaP was not significantly more, they deemed it safe. So they developed it because the other one was not safe. They tested it against the other one, and when the number and severity of reactions was not significantly greater, they deemed this one safe. All right, so we're clear on that. So according to VAERS, as of September 14th, 2014, which is the latest data, there were 20,449 emergency room visits reported for DTaP, 7,047 serious adverse events, 5,532 hospitalizations, 745 patients disabled, 954 life-threatening reactions, and 820 deaths. Yes? Dr.
Were
Cady.
those numbers over the calendar year, January 1, 2014 to there, or?
No, this is from the beginning of the vaccine adverse events reporting system to now, okay? So let's remember too that we are talking about a small percentage, according to what the American Medical Association says, vaccines injuries that are reported. And I can testify to that because my daughter had a seizure 3 hours after she got her Tdap vaccine at the age of 15. And I called from the ambulance, called the doctor's office from the ambulance and said, I want this reported. I was talked into it, I knew better, so I knew about VAERS. And It was 7 months later that I found out it was never reported. Called the doctor's office and asked them, why wasn't it reported? They said, did you bring her back here? I said, no, I took her to the hospital because she had a grand mal seizure and stopped breathing and had to be resuscitated. So they said, well, you didn't bring her back here, so the hospital physician should have reported it. So I called the hospital and said, why didn't you report it? And they said, we didn't give the vaccine. So I called Health and Human Services and I said, who should have reported this? And they said, either one should have reported it. I said, well, neither one did, so isn't that mandatory? And she said, yes. And I said, so what happens to them that they didn't, because they didn't report it? She said, well, there are no consequences. I said, if there's no consequences, that's not mandatory, just a suggestion. That's why we have such low numbers. So, next question, does it work? This is a study published in the Proceedings of the National Academy of Sciences of the United States of America, and this was from, I believe, 2010. I don't see the date on it here. But acellular pertussis vaccines protect against disease but fail to prevent infection and transmission in a non-human primate model. Again, going to the primate studies. All right, so what they found was, down here, vaccination with whole cell pertussis and previous infection induced a more rapid clearance compared with naive and acellular pertussis vaccinated animals. While all groups possessed robust antibody response, key differences in T-cell memory suggest that acellular pertussis vaccination induces a suboptimal immune response that is unable to prevent infection. These data provide a plausible explanation for pertussis resurgence and suggest that attaining herd immunity will require the development of improved vaccination strategies that prevent B. pertussis colonization and transmission. The vaccine does not work, and it is not preventing infection. So when people are urged to go and get vaccinated to cocoon babies, they're not doing anything to prevent the spread of pertussis infection. This is also a very strong argument about the fact that it is not the unvaccinated who are spreading the disease. All right, so this is the same study. So according to this study, baboons, and this was another baboon study, this was a primate study, okay, very close to humans. Baboons who are vaccinated can still harbor the bacteria in their throats with or without symptoms and spread it to others. If an unvaccinated child has pertussis, okay, so if an unvaccinated child gets pertussis, you're going to know it, right? Parents will know and can take steps to stay away from newborns. If the results of this study hold true for humans, a vaccinated child or adult can hug and kiss a newborn and spread pertussis without even realizing it because they think they're protected and they're not. All right, so pertussis is also mutating. This study, this is actually a report of a study from the Centers for Disease Control and Prevention, CDC, on emerging infectious diseases. And they found rapid increase in protectin-deficient Bordetella pertussis isolates in Australia. So what that means is that the disease that the vaccine is supposed to protect us from is changing. And why should we be surprised by that? It's a bacteria. It's one of several bacteria that are associated with whooping cough. When you go to your doctor and you have a bacterial infection and the doctor says to you, I want you to take this antibiotic exactly as directed. Do not stop taking it when you feel better. Take it even until it's all gone, because if you don't, what happens? The bacteria is going to change and the antibiotic is no longer going to be effective against that bacteria. If that can happen in the course of a 7 to 10 day antibiotic administration, how are we supposed to believe that a vaccine that was developed against one strain, Bordetella pertussis, in the 1990s, early 1990s, is still effective at fighting pertussis? It's not. And it is causing the mutation. So Bordetella parapertussis is one of those other strains that causes whooping cough. This is from California, and this is, I couldn't find the study rapidly today, But there are other studies backing this up. This is from the California Department of Public Health, July of 2011. And we keep hearing about all these big outbreaks in California, and they're all because unvaccinated children are spreading whooping cough, right? That's what the media wants us to believe. Well, right down here it says incidence of disease. It is estimated that 1% to 35% of known Bordetella infections are caused by Bordetella parapertussis. Outbreaks are known to occur and have been reported recently in California. Bordetella parapertussis is the one that is not covered. It's one of a handful that are not covered. This says up to 35%. I've seen studies that say up to 40% are caused by parapertussis. DTaP and TDAP vaccines increase Bordetella parapertussis in the lungs of mice. Here's another lab study. What this says, and this is from the Center for Infectious Disease Dynamics, and that's at, I believe it's at University of Pittsburgh. It's at one of the universities in Pennsylvania. So what they found, their data showed no within-host competition between Bordetella pertussis and Bordetella parapertussis, as well as a strong acellular vaccine-induced protection against infection with Bordetella pertussis in both singly and co-infected mice. So they can get both. People can be infected, mice can be infected. I don't know if people can be infected, but if this holds true for people, they can be infected with both at the same time. So what this says is the vaccine does not protect at all against Bordetella parapertussis. In contrast, vaccination led to a 40-fold enhancement of Bordetella parapertussis colonization in the lungs of mice. The vaccine is causing the outbreaks of parapertussis. So, again, the reason the acellular was developed is because it is safer than the whole cell pertussis vaccine. So these are deaths reported to VAERS, and this is 1990 to 2014. We no longer use the whole cell pertussis vaccine in the United States, but it is used in other countries, and there are reports from those countries in the VAERS database, and it states on there that it's foreign. So we have data from 1990 to 2014. There were deaths, 768 deaths reported for DTaP, with 729 in children under 3 years, so 95%. And the TDAP, the acellular version, has 820 deaths reported from 1993 to 2014, with 779 children also under 3 years, so 95%. So how is it safer? So what about combo vaccines? Pentucell is a combo vaccine that includes DTaP, polio, and Haemophilus B. So that's 1, 2, 3, 4, 5. So that's why it's called Pentucell. There were 188 deaths, including 185 children under 3 years for 98.4%. And the dates on that were 2008 through 2014. So this has only been licensed since 2008. Pediatrics is another that contains DTaP, and it contains hepatitis B instead of Hib and polio. There were 296 deaths with 292 children under 3 years for 98.7. The thing that is important to know about these vaccines is, in general, the more vaccines are included in these big multiple vaccination shots, the more aluminum they have in them. So the higher the aluminum. And I don't have it right in front of me, but one of these has 850 micrograms of aluminum in the vaccine. I think it's the bottom one. Okay, so let's talk about Gardasil. And I'm getting now to, Dr. Cady said, give me the top 3. All right, so we've talked about DTaP, which I also include TDAP in that, the acellular pertussis. And when we talk about the dangers, what's the most dangerous? It's not just, as we just talked about, it's not just about the vaccine reaction. It's about the false sense of security that people have that they're being protected. Okay, so we talked about that, and we talked about hepatitis B. Those are the first 2. Now we're going to go to Gardasil. And what I want you to realize is that when Dr. Cady says, what are the top 3 vaccines? the three worst vaccines, the three most dangerous vaccines? The answer is it depends on who you are. It depends on if you're an infant getting the hepatitis B vaccine, or if you're a child or an infant whose parents and family are cocooning with what they think is going to be protecting. And then Gardasil, obviously, we're going to move into teenagers. So these are some of the reports to VAERS for Gardasil. And actually, I thought I had deleted this because I went through all of this last year, or last week in the presentation that I did. But just syncopal episodes and seizures were 1/4 of all reports filed after Gardasil vaccination. And so this neurological adverse events, including loss of consciousness, syncope, syncopal evidence, and seizures. Syncope is defined as a temporary suspension of consciousness due to generalized cerebral ischemia, inadequate blood flow, and lack of oxygen. What I want to say about this is, when you talk to people who are very pro-vaccine, and you talk about the number of deaths that's been reported for Gardasil, in the reports, it includes car crashes. And they're like, oh yeah, vaccination caused a car crash. Well, we're vaccinating teenagers who are driving and who are at increased risk of loss of consciousness. So yeah. Additionally, there were reports of dyskinesia, difficulty or distortion in performing voluntary movements, and hypokinesia, slow or diminished movement of the body musculature, both of which have neurological implications. Gardasil has a lot of neurological implications. Gardasil has 225 micrograms of aluminum. So the question is, what's the risk? Is it worth it? HPV is the most common sexually transmitted infection in the United States. Most HPV infections cause no symptoms, and up to 80% of all sexually active persons become infected at some point in their lives. There are more than 100 HPV, which is human papillomavirus types, and 30 to 40 can be sexually transmitted, with 15 HPV types associated with cervical cancer. The majority of women clear the HPV virus from their bodies naturally, but women with risk factors such as HIV infection, smoking, long-term use of oral contraceptives, and co-infection with herpes simplex virus or chlamydia are at higher risk for chronic HPV infection. Chronic HPV infection is associated with precancerous changes in the cervix, which can progress to cervical cancer if left undiagnosed and untreated. From 1955 to 1992, cervical cancer deaths in American women dropped by 74% due to routine Pap smears. That's what diagnosis does, early diagnosis and treatment. Pap smears. There are about 9,800 new cases of cervical cancer annually diagnosed in the U.S., which represents 0.71% out of the approximately 372,000 new cancer cases of all types diagnosed. In the U.S., cervical cancer is the 14th most common type of cancer in women, but in South America, Africa, and Asia, cervical cancer is the most common cancer in women because of poor health care and no Pap screening. So I'm going to just go back here real quick. There are more than 100 HPV types, and 30 to 40 can be sexually transmitted, with 15 HPV types associated with cervical cancer. Remember what I said about the Pertussis bacteria changing? That also happens with other bacterial infections or other types of bacteria. Bacteria and viruses have been around since the dawn of time, and they change their shapes. They change and they shape shift, and they attempt to avoid eradication. So if we have 15 types now that are associated with cervical cancer, guess how many Gardasil covers of those 15? 2. Gardasil covers 4 types of HPV, but only 2 of them are associated with cancer. So there are 13 out there hanging around. All right, did that one. So there are about 3,700 deaths in mostly older American women annually attributed to HPV-related cervical cancer, which is about 0.65% of the approximately 570,000 cancer deaths that occur in the U.S. Most cervical precancers develop slowly, so nearly all cervical cancers can be prevented with regular pap smear screening and prompt treatment. Survival for women with pre-invasive cervical cancer lesions is nearly 100% with early diagnosis and appropriate treatment. What the vaccine does is it gives a false sense of security and will encourage people not to get regular pap smears because they think they're protected. Serious injuries and deaths reported to VAERS as of September 14th for Gardasil: 11,660 emergency room visits, 4,239 serious adverse events, 3,157 hospitalizations, 1,022 patients disabled, and 590 life-threatening, and 158 deaths. And this is increasing all the time. What just astounds me is that in other countries, they have suspended Gardasil program after 5 girls died. Or 7 girls died. They said, nope, we're not doing this. In the United States, we've got 158 deaths reported so far. Gardasil was fast-tracked and it just hit the market in 2006. And they're lowering the age, and they've now added boys. So they started out with women 19 to 26 years. Then they lowered it down to 11 or 12 for girls. And then they lowered it down to 9 and they added boys. And just like the hepatitis B vaccine, first day of life, they're going to add it to the infant schedule. And the reason they're bringing it down slowly is because they're lulling us into a sense of security. Everybody, if they had said initially we're going to put an HPV vaccine in the infant schedule, there would have been an uproar. But they're sneaking it in, and the reason they're doing it, Gardasil, the 3-shot series for Gardasil is almost $400 per person. So with 4 million infants born in the United States every year, if you can vaccinate 100% of them, how many billions of dollars is that? Okay, Dr. Cady, number 4, flu vaccines. Deaths reported to VAERS as of September 14th, 2014. This is the total number of deaths reported for flu vaccines, all of the flu vaccines, 1,147. And these are the ones that have been reported. H1N1, everybody was, H1N1, that was such a huge deal. 85 for H1N1, 85 deaths were reported to VAERS. This is another H1N1 brand, Flu X, 50, so 135. Flu Arix, which is a quadrivalent vaccine, has 5 deaths reported. Flu Mist seasonal vaccine has 14 deaths reported, and Fluzone trivalent has 1,013. This is the one that is most widely used. It is approved for everyone over the age of 6 months. It is the injectable version of the vaccine, which has it's not a live virus, it's not technically a dead virus, but people always talk about it being a dead virus. Okay, so it's not the Flu Mist. So that's what's been reported. So Fluzone, breaking it down to Fluzone, serious injuries and deaths reported to VAERS. 27,712 emergency room visits, 10,399 serious adverse events, 7,960 hospitalizations, 1,763 patients disabled, 2,066 life-threatening reactions, and 1,013 deaths. Now, what we need to remember about this is how many people got, compared to now, when we've got flu clinics in schools and we've got CVS and Walmart and Schnucks and all of these places giving flu vaccines, it wasn't just a few years ago, only people who were targeted for flu vaccines were those over the age of 65. In 2009, they started targeting adults. In about 2003, they really started targeting infants. One of the things I wanted to say about that I didn't include in this is a vaccine manufacturer's insert. This happens to be for Fluzone. This is very different from what you get from your doctor. When you go to the doctor and the doctor gives you that one little sheet, sometimes before you get the vaccine, sometimes afterward, and says, here, sign this. That's illegal. They're supposed to give it to you before. You're supposed to be informed, right? Well, that's one sheet. This is not numbered, but probably 20-something pages. Most of them are between 20 and 30 pages. This includes the information about reactions, precautions, adverse reactions, and clinical studies. This is the 2014 Fluzone manufacturer's insert. Okay, so I'm looking at adverse reactions, clinical trials experience. And here it says, children 6 months through 8 years of age. In a multi-center study conducted in the United States, children 6 months through 35 months of age received 2 doses of Fluzone, and 3 years through 8 years received 2 doses of Fluzone. And the 2 doses, and then in parentheses it says 2006-2007 formulation. So they're testing, they're providing clinical data on the Fluzone that was developed in 2006-2007, and they're using that data for the Fluzone for 2014. The Fluzone in 2014 contains H1N1. H1N1 wasn't discovered in 2006-2007, so it's a completely different vaccine. And they're using the clinical data on adverse events for a different vaccine. And this is very, very common. Throughout this, they use different vaccines. None of the data that they give on the efficacy or the the clinical trials regarding reactions is for this vaccine. It's for an earlier version that did not contain H1N1. So I wanted to make sure I mentioned that. Okay, so what about DTaP and flu shot while pregnant? Fluzone. Use in specific populations. Number 8, pregnancy. Pregnancy, category C. Animal reproduction studies have not been conducted with Fluzone. It is also not known whether Fluzone can cause fetal harm when administered to a pregnant woman or can affect reproduction capacity. Fluzone should be given to a pregnant woman only if clearly needed. That's from the vaccine manufacturer's insert. And yet, every pregnant woman is supposed to get Fluzone or flu vaccine, and Fluzone is the one that's most widely used. So this is from the VAERS data, spontaneous abortion or premature birth, 344 cases for flu vaccine and 59 cases for DTaP vaccine. DTaP also contains, the insert contains similar language about pregnancy. However, those are low numbers. This is a study that was conducted by the National Coalition of Organized Women, looked at I'll just read this. Vaccine-related fetal demise reports from VAERS increased 2,440% from 7 cases in 2007-2008 to 178 in 2009-2010. 70 deaths reported from another source had 7 overlapping cases with VAERS, yielding 241 unique cases. Simplistically speaking, it would have been 85 to 192 times safer not to vaccinate from the perspective of the in utero child. Again, what's the most dangerous vaccine? It depends on who you are. So does the flu vaccine work? This is from the Cochrane collaboration, which is one of the world's most prestigious research groups. And they look at meta-analyses, they look at the research. They are researchers who look at the research. And they looked at many studies of flu efficacy studies and safety studies published since the 1960s. Thousands and thousands and thousands of subjects in multiple studies. Parenterally administered influenza vaccines, which is Fluzone, the vaccine, not the nasal mist, appear significantly better than their comparators, so better than the nasal mist, and can reduce the risk of developing influenza symptoms by around 4% if the World Health Organization recommendations are adhered to and the match is right. Every year, they try to figure out what flu viruses are going to be going around, and they make a guess. So if they're right, it may reduce symptoms by around 4%. And that's for the injectable kind. Okay, and the injectable kind is better than the mist. So this is good stuff here. So however, while the vaccines do prevent influenza symptoms, this is only one part of the spectrum of clinical effectiveness, as they reduce the risk of total clinical seasonal influenza-like illness symptoms by around 1%. When the results of our analysis are expressed as risk difference, the effect appears minimal. This is remarkable, as healthy adults are the population in which inactivated vaccines performed best. So this is a best case scenario. We found no evidence that vaccines prevent viral transmission or complications. False sense of security. This is what the Cochrane collaboration had to say about the CDC. The content and results of previous versions of this review have been extensively misquoted, especially in public policy documents. Two types of common misquotes are the generalization of evidence from this review to all age and risk groups, and the generalization of estimates of effect to all outcomes, especially complications and deaths. So, in other words, they're making it sound better than it is for everybody else, because what we just saw, 4% effective and 1% at preventing flu-like illness, is the best it gets, and they're underestimating complications and deaths. The misquotes then assume that the performance of influenza vaccines is uniform across all age groups and from symptom prevention to all outcomes. Both generalizations are not supported by any evidence and seem to originate from the desire to use our review to support decisions already taken. Recent examples of misquotes of this review come from page 11 of the 2009 ACIP document, which includes recommendations for pregnant women to get the flu shot. The CDC authors clearly do not weight interpretation by quality of the evidence, but quote anything that supports their theory. So, just a little note about shedding and flu mist. Flu mist is a live virus vaccine. Other live virus vaccines include the MMR, measles, mumps, rubella, chickenpox, shingles. All of those live virus vaccines contain in their manufacturer's inserts information that instructs doctors to tell recipients and families to caution them about the possibility of shedding and infecting others, particularly those who are immunocompromised. Immunocompromised household contacts is what it says. That includes this one, flu mist, which is what they're giving to children in schools, school flu clinics. There are immunocompromised children in classrooms, and those kids are spending 7 or 8 hours a day together, and nobody is warning anybody about what's going on and about what the manufacturer's insert. This comes straight from the flu mist manufacturer's insert. So what this says is, you see here, this is number of subjects, percent shedding, 89%, 69%, 50%, 29%, 20%, the peak titer, and percent shedding after day 11. 7% of preschool kids, little ones, 1% of 3 to, those are preschool kids, 3% basically of 5 to 8-year-olds, 1.6 of 9 to 17, and 0.9 for the older ones there. So, and the last day of positive culture up to day 28. Okay, so these kids are getting not 1 but 2. They get 2 doses, and they can be shedding for 28 days, which means they're shedding for 2 months. So in clinical trials, up to 7% of 100 children every 100 children who received flu-mist live virus vaccine were still shedding the live flu virus for up to 28 days post-vaccination. In a school of 300 kids, up to 21 recently vaccinated students could be spreading the flu to everyone they come in contact with during a 4-week period of time. Which raises the question, what causes the flu season? And it also highlights the fact that if you have a child in school, it is not the unvaccinated children who are making other children sick. So, do vaccines make kids healthier? This is a study that was done in the Netherlands, and it shows average incidence first 5 years of life. And these are fully vaccinated and no vaccinations. Ear infections, fully vaccinated, not vaccinated. Inflammation of the throat, vaccinated, not. Aggressive behavior events, vaccinated, unvaccinated. Convulsions and collapse, vaccinated, unvaccinated. Antibiotics administered, vaccinated versus unvaccinated. And down here we've got same vaccinated and unvaccinated. Sickly, vaccinated, unvaccinated. Eczema, vaccinated, unvaccinated. Asthma, vaccinated, unvaccinated. Allergic reactions, vaccinated versus unvaccinated. Aggressive behavior, vaccinated versus unvaccinated. And difficulty sleeping, vaccinated versus unvaccinated. This study has not been done in the United States. The CDC has been asked many, many, many times to do a vaccinated versus unvaccinated study. And it's not been done. And as one of my friends really pointed out, because a lot of people are like, just do the study, do the study. Given that they're still trusting Paul Thorson and his study results, even though he's one of the FBI's most wanted, and given that they are continuing to employ William Thompson and gave him a raise, even though he came forward and admitted doing away with data and breaking the study protocol, do we want the CDC to do a study of unvaccinated versus vaccinated kids? I don't think so. Would we be able to trust what they said? So these are some graphs from a website called preventdisease.com. And what this is just kind of showing how vaccines really did not save us from pertussis, okay? This is USA mean annual pertussis mortality rates per 100,000 people from 1918 to 1960. So here's 1918, way up here, and falling, boom, and that's when the vaccination was introduced. Okay, and this is influenza, USA, 1933 to 1965. So 1933, way up here, falling. Vaccination, influenza vaccination, first widely administered in the US in the late 1980s, way over here. This is Canada measles. I couldn't find the one that matched these. I really wanted them to match and be pretty for the United States. But Canada's in North America and very similar kinds of environmental events. So this is Canada measles reported incidence 1935 to 1983. 1935 over here, falling. Measles vaccines introduced 1963 right here. Boom. And this is the US mean annual scarlet fever rate. And we don't have a vaccine for scarlet fever. But 1910 to 1958, falling, and no vaccine. So what does that mean? Something else is causing the decrease in the mortality rate and in the incidence of these diseases. It's not vaccines, it's clean water, it's better living conditions, less overcrowding, better nutrition. So the final thought on vaccines and the decrease in deaths from infectious diseases is correlation does not equal causation. So when people tell you vaccines have saved us and vaccines are the best thing in the medicine and the vaccines have been the #1 medical advancement in history, you can tell them, prove it. Correlation does not equal causation. And this is a quote from my friend Lisa Joyce Goes, who is one of the editors of the book, The Thinking Mom's Revolution. She was interviewed recently on MSNBC, mainstream media, finally, about vaccines and about her son's iatrogenic autism, which was vaccine injury. And the last word that she got in just as they were going away was, parents, do the work. Because you're not going to get the truth unless you take the time to look at the manufacturer's inserts, to research, and to take the time to really understand. Because the vaccine manufacturers are not going to be they're not going to be responsible at all if something happens to your child, if your child dies, or if your child develops autism or has a serious reaction. Vaccine manufacturers are indemnified. They don't do anything. Doctors are indemnified. You can't sue the doctor, you can't sue the nurses, you can't sue the hospital, you can't sue anybody. And you're left holding the bag. So we need to do the work. We need to take the time and educate ourselves. So